So good morning students. In this unit of blood, so we are taking a very important topic. We are starting with fibrinolytics and antifibrinolytics. So what you can see in this picture that there is coagulation because of rupture of the atherosclerotic plaque, which can result in clot formation and leading to myocardial infarction. Now let's understand the pathophysiology behind this myocardial infarction. So whenever there is collagen exposure due to the vessel injury, now platelets क्या करते हैं कि adhere होना शुरू कर देते हैं collagen से जो expose हो रहा है, and there is activation of the glycoproteins. Now this will release the inflammatory mediators like serotonin, thromboxane A2, and this platelet phospholipids. They will get exposed and they will activate the blood coagulation cascade. Now this also in turn will activate the final receptor GP2B3A, now which binds to the fibrinogen and then fibrin, which get converted to the fibrin with the help of the thrombin. So thrombin converts the fibrinogen to fibrin, and this platelet get aggregated with fibrin to form a stable hemostatic plug. Serotonin will in turn result in vasoconstriction and will narrow it and causes further the aggregation and formation of the hemostatic plug. Now how these fibrinolytics they work therapeutically. What does that mean therapeutically is that they helps in dissolution of the clot, while the other drugs like heparin or aspirin by acting on the other mechanisms, like by aspirin कैसे work कर रहा है by inhibiting the thromboxane A2, और heparin कैसे कर रहा है by inhibiting the thrombin to convert the fibrinogen to fibrin. Now they actually prevent the clot formation, while fibrinolytics क्या करते हैं, they helps in dissolution of the clot. So अगर clot form हो गया है, so at that time therapeutic drug which is available is fibrinolytic. So the objective for the today's class is, at the end you should be able to classify these fibrinolytics and antifibrinolytics, describe their mechanism of action, uses and adverse effects, and enumerate their contraindications. So what is the mechanism of these fibrinolytics? कैसे काम करते हैं? They convert the plasminogen to plasmin. और प्लाज्मिन का क्या रोल होता है? ये क्या करता है? फाइब्रिन जो इनसॉल्युबल फाइब्रिन फ्रैगमेंट्स हैं उनको सॉल्युबल फाइब्रिन फ्रैगमेंट्स में कन्वर्ट कर देता है. इट कॉजेज द ब्रेकडाउन ऑफ द फाइब्रिन and thus dissolution of the clot occurs. Now normally what happens is this tissue plasminogen activator is converting the plasminogen to plasmin. Now this works similarly by the same mechanism of the tissue plasminogen activator converts the plasminogen to plasmin, and whatever the extra plasmin is there, it get neutralized by antiplasmin or alpha 2 macroglobulin, which are the inhibitors of the plasmin, or there is inhibitor of the tissue plasminogen activator, that is plasminogen activator inhibitor 1. Now this together they balance and they prevent the bleeding to occur and also the clot formation. So these are the fibrinolytic drugs. You have streptokinase, urokinase, alteplase and tenecteplase. Now they works by converting the plasminogen to plasmin in the similar mechanism or by as it works by tissue plasminogen activator. Then you have these antifibrinolytic drugs like epsilon aminocaproic acid and tranexamic acid. It inhibits the plasminogen to convert to plasmin, and it acts as an antidote to these fibrinolytic drugs. So what is the mechanism? Mechanism is converting the plasminogen to plasmin. Now plasmin will helps in breakdown of the fibrin, insoluble fibrin to the soluble fibrin fragments and dissolution of the clot. Now on which thrombi does they work better and why? They work better in the venous thrombi compared to the arterial thrombi, because venous thrombi are more rich in the fibrin components and more, while the arterial thrombi are more rich in the platelet components. So this works better in the venous thrombi. Now you have these drugs. Now what is the difference in the mechanism of or in the properties of these drugs? Now all these drugs, how it differs is streptokinase was the drug which was the first came by beta hemolytic, produced from beta hemolytic streptococci. Now these are the altiplase, ratiplase and tenecteplase. These are the recombinant form of tissue plasminogen activator. ये टिश्यू प्लाज्मिनोजन एक्टिवेटर की रिकॉम्बिनेंट फॉर्म है. अगर हम प्लाज्मिनोजन के एक्टिवेशन की बात करें तो इट इनडायरेक्टली बाइंड स्ट्रेप्टोकाइनेज वाइल दे बाइंड डायरेक्टली टू द टिश्यू प्लाज्मिनोजन एक्टिवेटर. सो इनडायरेक्टली बाइंडिंग का मतलब है ये प्लाज्मिनोजन की को एक्टिवेट करता है इट and then the plasminogen get converted into the plasmin. While they work as tissue plasminogen activator, they directly converts the plasminogen to plasmin. Now fibrin selectivity is not there whether it is bound to the thrombi, fibrin bound or not bound. It converts the it causes the fibrin dissolution, while there is they act only on the plasmin which bound to the clot. There is a chances of development of allergy with fibrinolytic like streptokinase, but it is not there with the recombinant form like altiplase, ratiplase or tenecteplase. Intravenous administration, infusion you have to give with the two drugs like these drugs like altiplase and streptokinase because they are short acting, while ratiplase and tenecteplase are the drugs which can be given by bolus administration and they are longer acting and also known as bolus fibrinolytic drugs. So streptokinase, though it is least expensive compared to the recombinant form, but second time if you are administering the streptokinase, it may leads to allergic reaction because it produces neutralizing antibodies and you have to be very careful if you are giving second time streptokinase drug because it can produce allergic reactions. Now bleeding chances are there with all the drugs and there are similar chances of bleeding with all the drugs. Now what are the indication where these fibrinolytic drugs are used is they are used in acute ST elevated myocardial infarction and within 12 hours of onset. So fibrinolytics, the golden hour जो हम कहते हैं उसका होता है 1 hour. Within 1 hour अगर आप fibrinolytic दे रहे हो it is useful. Otherwise अगर 2 hours and more it is advisable to use the emergency percutaneous angioplasty rather than fibrinolytic drugs. Though it can be used till 12 hours of onset, if you don't have the facility for the percutaneous angioplasty, then you can be use fibrinolytic drugs, but better the advisable is percutaneous angioplasty and then fibrinolytic drugs can be used. It can also be used in deep vein thrombosis, pulmonary embolism, peripheral artery thromboembolism, for unclotting of catheters and shunts, and acute thrombotic stroke within 3 hours. But you have to be very careful, it shouldn't be a hemorrhagic stroke. If it is diagnosed as a thrombotic stroke within 3 hours, you can use the fibrinolytic therapy. So what is the role of aspirin and heparin after the thrombolytic therapy? Now when you give this thrombolytic therapy or a fibrinolytic therapy, now there is chances that reocclusion can occur. So reocclusion, to prevent that reocclusion, you have to give aspirin and heparin after giving this fibrinolytic therapy, especially if you are giving altiplase or these short acting drugs. You have to give the heparin with these drugs. What is facilitated percutaneous intervention? Facilitated percutaneous intervention होती है जब आप with angioplasty you are also administering the fibrinolytic drugs, that is known as facilitated percutaneous intervention. Now what is the main complications क्या रहती हैं इसके साथ? That is bleeding or the hemorrhagic stroke is the main complications with these fibrinolytic drugs. Now contraindications क्या हैं इसकी? These are the contraindications. We have to make sure कि इनमें आपको ये fibrinolytic drugs नहीं देनी है. If there is a history of intracranial hemorrhage, if there is a history of ischemic stroke in past 3 months, अगर कोई ischemic stroke है, हेड इंजरी का कोई केस है, या इंट्राक्रेनियल ट्यूमर या वैस्कुलर एबनॉर्मलिटी या एन्यूरिज्म का कोई केस है, या एक्टिव ब्लीडिंग या ब्लीडिंग डिसऑर्डर्स हैं, पेप्टिक अल्सर या इसोफेजियल वेरिसेस हैं, एनी वूंड और रीसेंट फ्रैक्चर और टूथ एक्सट्रैक्शन इज देयर, और इफ देयर इज अ हिस्ट्री ऑफ मेजर सर्जरी विद इन 3 वीक्स, और इफ देयर इज अनकंट्रोल हाइपरटेंशन और प्रेगनेंसी, इन सभी में चांसेस हैं ब्लीडिंग होने के, and therefore these are the contraindications to this thrombolytic therapy. So let's see this question. A patient of acute myocardial infarction has been brought to the ICU. What is the time lapse since symptom onset beyond which you will not consider instituting the thrombolytic therapy? So beyond which is, ideally it should be within 3 to 6 hours, but beyond 12 hours it should not be instituted. So the answer is C, that is 12 hours. Now coming to the antifibrinolytic drugs, you have this epsilon aminocaproic acid and tranexamic acid. So now we prefer more of the tranexamic acid because it is 7 times more potent than epsilon aminocaproic acid. Now where it is used to control or prevent the excessive bleeding which can occur because in these conditions, like because of fibrinolytic drugs, or if there is a cardiopulmonary bypass surgery, it may leads to hemorrhage or excessive bleeding, tonsillectomy, prostatic surgery, tooth extraction, or in hemophilia, menorrhagia, especially due to intrauterine contraceptive devices, वहाँ पे भी bleeding जब हो रही है, recurrent epistaxis है या hyphemia है due to ocular trauma, then if there is a peptic ulcer, in all these cases if there is a bleeding, you can use these antifibrinolytics. How they work? They works by inhibiting the plasminogen to convert into plasmin. Adverse effects क्या हैं? Just the opposite. They will have thromboembolic events. They can cause thromboembolic events. And epsilon aminocaproic acid, if you are giving this rapid IV infusion, you have to be careful about these side effects like hypotension, bradycardia and arrhythmia. You have to be very careful if you are giving them IV epsilon aminocaproic acid. So that's it. We'll start with the antiplatelet agents in the next class. Thank you.